Now, extreme tiredness, brain fog and insomnia are just some of the symptoms associated with ME, or chronic fatigue syndrome. The illness can be triggered by COVID-19 and is almost indistinguishable to long COVID.
There are no official figures, but the charity Action for ME estimates 250,000 people are affected in the UK, with many of them saying they feel the illness isn't taken seriously.
Campaigners say more needs to be done to understand the condition. Our correspondent Sophie Long went to meet some of those living with it.
We were incredibly happy. I mean, we're just in love. We got married. We had a lovely wedding. It was the summer. I remember it was the hottest day of the year, I think. Had a lovely wedding in a pub with a nice beer garden. And we went on honeymoon. We had a lovely time. James was loving his job. He was kind of, he's a big runner. I was loving work. I work in the humanitarian sector. I was working then with the Red Cross. I was flying all over the world. We just had a very, very busy, very full, happy life.
The happy life that Karen and her husband James once had fundamentally changed when they both contracted long COVID, which developed into ME. While Karen has managed to recover enough to now work part-time, James's condition has become more and more severe.
We can't have a conversation, I can't give him a hug, can't sit with him and hold his hand. It's just, there's just a life that we had before which is just gone, and there's a grief that comes with that is just taking us both a lot of time to be able to process and kind of work through properly.
When was the last time you heard his voice?
I think over a year ago. Yeah, it's been over a year now. And I miss it. Yeah, I miss his voice, I miss his laugh, I just missed everything about him, really.
Karen says while some doctors have been empathetic, others haven't.
When he was having very bad difficulty swallowing, to the point that I was worried that he might end up in hospital because he wasn't getting the hydration, I sort of spoke to a doctor on the phone, and I just really vividly remember them saying, well, is it that he can't drink, or is it that he doesn't want to? And I think none of these things feel that bad perhaps on their own when you're listening to them, but it's the accumulation really when you're just kind of constantly having those kind of interactions with healthcare. It wears you down, constantly worried that you're going to be disbelieved or dismissed.
Many others have had a similar experience, and so while Karen does her best to look after James with the help of a carer, she's launched a campaign called There for ME, calling for the government to take the condition seriously and ensure patients will be believed. Rowing was Oonagh's life. After years of dedication, she was selected for the Tokyo Olympics, but then she contracted COVID-19.
For months, I couldn't believe that a mild infection, it was so mild, the initial cold, could lead to this all these ongoing health problems. So when I finally realised, okay, this is not going away, and we made the decision that I was not going to try and get reselected for the postponed Olympics, it was completely devastating. I couldn't believe it was happening. Yeah, this is mine, quite dusty as you can see.
Oonagh spent a year and a half out of sport trying to get better. When she was well enough to train again, she quickly suffered a devastating relapse and was forced to retire. Her boat left to gather dust.
Yeah, I mean, it's sad. There's this grief. This is a life not lived.
As a professional sports person, her condition was taken seriously.
I have data in a way that other people don't. I have training scores, and when I sit on a rowing machine, it's obvious that there's something wrong with me. And so even if they don't have a blood test that can find what's wrong with me, they know there is something. Whereas most people don't have that, right? You don't have scores of before and after.
Now she works for Oxford University, researching the impact and treatment of chronic fatigue.
As someone with long COVID, I feel very strongly that if we had done more to understand what is happening in people with ME, we would be in a much better place now to deal with all these people who have long COVID. And many of these people with long COVID are also developing ME. By one estimate, it's 50% of people with long COVID have ME. And just the broader historical context is that we don't understand infection-associated chronic conditions, which is the long-term health effects of viruses on people's bodies. And like a huge part of that is our neglect of ME.
What Karen fears most is that James could deteriorate further and be hospitalised.
There's just so much about this disease in itself that's terrifying, but having to be scared that the NHS isn't going to be there for you when you end up in the most extreme situation, it's just, yeah, it's just terrifying. I can't think of many other diseases where the more severe your symptoms are, the worse your care is, the way we see with ME.
Sophie Long reporting there. Now we're joined now by consultant respiratory physician Dr. Binita Kane, who is with us. Good morning, and retired specialist in ME and chronic fatigue syndrome. That's Dr. William Weir. Good morning to you too. And Dr. William, let me maybe start with you and make that link for you, for us, if you will, between long COVID and ME. How closely linked are the two?
Well, they're very closely linked. Long COVID is basically the remnant of an infection, which has led on to causing ME. And ME is well known to be triggered by a range of different infections, right the way through from Epstein-Barr virus to salmonella infections and even malaria. I've seen in one case with one patient. And so the common denominator is an immunological stimulus rather than any particular singular infection as such.
And over the course of your career, are you frustrated perhaps at the slow pace of change in the way people view ME?
Very frustrated because there is a competing theory promoted by a cabal of psychiatrists to the effect that this condition has a psychological basis. It doesn't have a psychological basis. And Dr. Melvin Ramsay, who first described a very significant outbreak at the Royal Free Hospital in the 1950s, was convinced that it had a physical basis. And I was able to talk to him about this about 40 years ago. When it comes to defining this physical basis, there are plenty of studies which confirm that. You can look at the spinal fluid of these patients and find evidence of an inflammatory disorder. You can do what are called positron emission tomography on the brains of these people and show little areas of inflammation here and there within the brain. And this has clearly got nothing to do with a psychological disorder. This is a physical disorder definable with these scientific approaches.
And Dr. Binita, then, given everything that we've heard there, why is ME still so misunderstood?
Yeah, it's very sobering to watch the stories every time, even though I work really closely with ME charities. There's so many people suffering. But when you look back through history of medicine, it's littered with examples like this. I mean, if you look back far enough, asthma, cancer, stomach ulcers were all thought to be hysterical in nature. But what has happened in those conditions is that we've had the scientific research that's translated into diagnostic tests and treatments. Therefore, we've trained doctors to deliver those treatments, and that's led to really good, efficient services. And then we measure the impact of those treatments, and the research in all of those areas is still very much ongoing. But that just hasn't happened in ME, and I think it's complex, and I think it is caught up in what Dr. Weir has been talking about, that there has been almost this willingness to continue to psychologise these illnesses. And now it's come back to bite us because we've got a magnitude of patients, nearly 2.2 million at the last estimate in the UK, suffering from long COVID, 500,000 of those with life-limiting, very disabling disease, and children, at least 112,000 children across the country, some of who are bedbound, all of whom are receiving some support, but there are no treatments, there are very few treatment trials, and for the scale of the problem, we have just not seen the investment that this condition needs, and there's been a lot of promises, a lot of reports, but what we need now is action.
I imagine that what lots of people who are suffering at the moment might need is some hope. Is there any hope of treatments or a combination of treatments that might help?
The good news is that certainly globally there is a lot of work going on to try and understand the impact of COVID, and that has led to a surge in research in ME CFS as well. And I do hope one of the good things that comes out of the pandemic is that we start finding solutions to ME. So there are treatment trials going on around the world, but I think the problem for the patients right now, like Karen and James and Oonagh, is they don't have access to those trials, and we're not doing the research quickly enough.
Dr. William, given how misunderstood it can be, this condition, what do people need to know to be able to support those who are dealing with it, who are living with it? How can you support someone who is living with ME?
I think it's important for someone who's closely involved in the care of such a patient, particularly a patient who's severely or very severely affected, is that their energy levels are very, very depleted, which means that they're usually unable even to get out of bed. And such voluntary activities as speech and chewing and swallowing and eating are directly affected by what I can describe as an internal battery, which instead of being charged to 100% is probably down about 5 or 10%. And such patients, as I say, are often so depleted in energy that they can only whisper, as we've heard earlier in the programme, and they need more care than practically any other illness that I have encountered in the past, because these patients, as I say, they are so weak that they need a lot of attention in that respect. The other situation which needs to be recognised is that they're often hypersensitive to both sound and light in a way which is somewhat reminiscent of the patients I remember with meningitis who needed to be nursed in side rooms with the curtains drawn. Any additional sound or light from the environment can be very problematic for the patient to tolerate. And that also is an extremely important issue to remember, particularly for patients who are admitted to hospital.
Yes.
Dr. Binita, and for patients who are suffering, I know one of the things in order to try and get into some version of a normal life that you suggest is pacing, isn't it? Not trying to do too much too quickly. How does that work?
So as Dr. Weir's alluded to, ME is as a result of a breakdown of the body's energy-making factory. And I sometimes explain this like a phone battery. So if I charge you up, you wake up on 100%. Someone with ME might wake up on 20. And then every single thing they do drains that energy. Therefore, they have to rest and recharge and rest and recharge. But they can also go into energy debt, which can be dangerous. It can result in a crash, a worsening of the baseline. And so it's really important these patients are taught how to manage their energy. But even now, because we've been taught the wrong things about ME, people are told, go back to the gym, get back on your bike, go out for a walk every day in the fresh air, and that can actually make people worse. And sometimes people are even prescribed graded exercise, which is harmful, and that has been very well debunked now and is out of the guidelines. So there's a lot we can do if we improved medical education. That is not easy. It's not a quick fix. We could start by implementing the NICE guidelines for ME that have been around for some years now. And at least patients can then start getting the right diagnosis and symptomatic support. But we also need that investment in the biochemical research, the clinical trials, and repurposing drugs that we know might be good candidates to help patients, but they don't have access to because the research isn't there.
Thank you so much. It's fascinating to hear some of those myths debunked as well. Dr. Binita and Dr. William, thank you so much for being with us and explaining that this morning. Thank you.